My name is Mike Fasano, and I'm founder of Fasano Underwriting. Um, I'm happy to have with us today Patrick Ning, who's the medical director at Fasano Underwriting. Patrick also serves as associate professor and director of research in the Department of Emergency Medicine at University of Texas Health San Antonio. He's board certified in both emergency medicine and medical toxology and brings extensive experience from clinical practice, military service, and translational research. Um, Dr. Ning received his MS and BS summa cum laude in chemistry from Northeastern University and his MD from the University of Vermont College of Medicine. Patrick will be speaking today on GLP-1 drugs and the future of longevity, extending lives or shifting risks. With that background, I'm very anxious to hear Patrick speak, and I'll turn the mic over to Patrick to begin his presentation. Patrick?
Great. Thank you, Mike. Good afternoon or good morning, depending on where you're joining us, everybody. Thank you for the time. Today we'll be talking about GLP-1s and GIP receptor agonists in this presentation entitled Targeting the Gut-Brain Axis for Weight Loss. And, with the penetration of the market with these drugs, I'm sure a lot of us have heard about them. So today we're going to be going over an overview of how these drugs came about and how they have penetrated the market, their efficacy for things like diabetes, obesity, and other comorbidities that have implications on longevity, as well as overall healthcare here in the United States and across the globe. And so, with our discussion today, really a fundamental foundation is how we kind of define obesity and diabetes. And so, obesity and being overweight is a process that is characterized by a measurement called the BMI, or the Body Mass Index, which a lot of us, I'm sure, are familiar with. And so just some major classifications across the board include under 18.5 as being underweight, normal generally from 18.5 to right under 25, and then our overweight categories of 25 to 29, and then obesity greater than 30. And one of the fundamental applications and theories associated with high BMIs really has to do with a calorie surplus in general. And here we have the energy balance equation, and it's fairly simple and fairly intuitive, right? That increased adiposity is generally associated with a higher calorie intake and decreased calorie expenditure, thus resulting in a calorie surplus, which most of the time gets transported and formed into adipose tissue, resulting in excess weight that we carry, and thus obesity and being overweight. And there is a trend here in the United States and globally of obesity on the rise. And so here we have some data trending obesity rates and BMI rates over time. And so you could see here in the y-axis, 0 to 50% of the population characterized by over the x-axis of the 1960s to right around the 2020s. And we can see here, particularly in the green lines plotted over time here, that there has been a steady rise in obesity rates in both men and women over time. And in the red/orange line on the bottom there, you can see a trend in the increase in severe obesity as well. And this is not just something that's seen in adults. The obesity trends over time in children have also shown a rise. And this is across all age groups, ranging from 2 to 5 here in the blue line, as well as up to the adolescent years into the early adulthood in the 12 to 19 years in the light green here, seen here as well. And so why is this important? We see a large, steady increase in the obesity and severe obesity rates over time. And one of the main issues of this is that the health impact of obesity is pretty well known, and that it's a global issue that affects pretty much every organ system in a negative way. And so, just to illustrate some of the main kind of organ systems that are affected or associated with higher rates with obesity include CNS. So, we have higher rates of peripheral neuropathy, cardiovascular disease, TIAs, and stroke, from the vision changes with diabetic retinopathy, and that plays into the endocrine system with diabetes and metabolic syndrome, pancreatic disease such as pancreatitis. We see higher rates of renal disease and increased rates of folks that develop end-stage renal disease and needing dialysis. We see hypogonadism at a higher rate with folks with obesity, and the list goes on and on. And so, this is not an exhaustive list, but you can already see that pretty much every organ system, from musculoskeletal to CNS to our endocrine system, are all affected and have higher rates in folks that are obese. And so, if we know that it's such a big problem from both the physiologic standpoint as well as a population standpoint, it seems like an easy fix if it was just explained by the calories in and calories out, right? Why don't we just increase exercise to increase calorie expenditure and decrease input by eating less? And that'll result in a change in adiposity favorable towards maintaining a healthy weight. But it's not just explained by a simple equation. And so there are different pieces of literature and different data out there that are now explaining that obesity and the increased trend of higher weights across the population are not just due to calories in and calories out, and that it's actually a very intricate interplay between various factors. Some of those that are explained include some environmental factors. So, what is around us, the location of where we get our food, the types of food that are inputted, genetic factors, and in fact, that there have been some risk alleles and different genetic factors that have been identified that increase the risk of obesity, and that this interplay between all of these things result in an energy balance dysregulation. And that energy balance dysregulation can also be explained with some hypotheses regarding the signaling involved. And so, from the molecular level, that in our bodies, normally, our hunger mechanisms are regulated by different hormones. And two big hormones that are the topic of the discussion today that are involved in this regulation process include GLP and GIP, which are released from the intestines and then signal to the brain, and essentially, from a very high level, help determine whether or not you're hungry or whether or not you're full. And that these signals help regulate the input by how much we eat and how much we drink. And part of this deeper explanation of obesity plays into potential dysregulation of this hormone signaling pathway that can contribute to some of the increase in rates of the obesity that we're seeing across the populations across the globe. And here are just some more of those other hormones. And so there's a balance between the satiety and hunger hormones normally, and that again, a dysregulation results in a relative deficiency in some of the hormones, such as GLP and GIP, resulting in increased calorie input and thus resulting in obesity. And so the hypothesis with the signaling involving that leads to obesity has led to a different paradigm, a different shift in how we think about obesity, and thus the different hypotheses that were generated from this understanding of the pathophysiology has led to some of the potential interventions that we are seeing in today's modern array of treatments for obesity. At the foundation of obesity treatment and healthy weight is balanced diet and exercise. And this has been around for decades, as you can imagine, of trying to regulate weight with a proper balance of these lifestyle changes. However, the data has shown that over time, these interventions result in about a 3 to a maximum of about 5% of weight reduction that is sustained. And so, with the rates of increased severe obesity as well as obesity rising, there was continued demand for other interventions that needed to be implemented to try to get a more impactful weight reduction, in addition to lifestyle interventions such as balanced diets and exercise. And that's really where some of the pharmaceutical interventions started to arise. And so in the late 1990s and early 2000s, different digestive enzymes and interventions that you could take exogenously started to hit the market. Different stimulants also started to hit the market. And early GIP-1, such as liraglutide, which was given orally at the time, were also introduced into the market. And so there were different therapeutic strategies that were developed around this time, but essentially, this was when the pharmaceutical interventions started to hit the market. And the data has shown that in addition to some of the lifestyle changes, we saw a more sustained weight reduction of about 7 to 10%. And then, of course, there is the surgical intervention. The gastric sleeve and the gastric bypass started to gain some traction. And resulted in about a 25 to 35% reduction in weight. And there are other surgical interventions, such as the gastric band and other kind of procedures, but generally, the category as a whole has shown quite a bit of reduction as well. And this is sometimes in addition to pharmacotherapy and lifestyle changes as well. But as you can see between these two, that there is a potential area of intervention where we have a large jump from the pharmacologic intervention to the surgical intervention of about 10% to almost 35% weight reduction. And so there is a treatment gap here of folks that might be able to benefit from more weight reduction than these initial first generation pharmaceutical interventions to potentially not wanting surgery. And today it still stands that bariatric surgery is uh, the the intervention that has the most impactful weight reduction, as you saw in the prior slide of about 25 to 35%. However, not everybody is a candidate for bariatric surgery. As you can imagine, with having to intervene with the size of the stomach and depending on which procedure you get, an anastomosis of something like a Roux-en-Y gastric bypass. It's a big surgery, and associated costs, morbidity, and pain associated with it might not contribute to decreased compliance slash appeal of these interventions. And so this is where some of the further developments of pharmaceutical intervention came into play. And so, as we talked about the pathophysiology of obesity potentially involving dysregulation of signaling, particularly hormone signaling, that optimizing that type of signaling slash intervening with exogenous signals such as GLP-1 or GIP, could that potentially restore the proper signaling or enhance that signaling to have an effect? And that effect being decreasing rates of obesity and sustained weight loss. And that's exactly what was developed with some of the drugs that you might have seen on commercials or know somebody that might be on them, of replacing slash increasing that signaling through exogenous administration of things like GLP-1 and GIP. And some of the data has shown that this has been fairly effective. And so dulaglutide is one of the early GLP-1s that was exogenously administered via subcutaneous injection. And in this study, the Award 11 trial, patients that were already on metformin and had a diagnosis of type 2 diabetes were enrolled into a randomized controlled trial looking at different doses of dulaglutide administered. And this is what was seen. At 36 weeks, the primary endpoint of a change in hemoglobin A1C, which is the marker for diabetes and the marker for glycemic control over time, As you can see in the first panel here, the letter C panel in the top portion of the figure here, the line graph shows the different doses of dulaglutide that were administered, with the blue line showing 1.5 and then an escalation to the red line of 4.5 milligrams. And these were weekly doses that were given. And at 36 weeks, which was the primary endpoint measurement, you can see that there was a steep decline in the hemoglobin A1C from baseline to about a 1.5 to almost 2% reduction in hemoglobin A1C. And then if you go down to H, looking at the escalating doses and the weight, this plot was with the weight changes. At 36 weeks, we see a significant reduction in weight and a more profound impact with escalation of doses of the exogenous GLP-1 administered. And the data was tracked 52 weeks out, and as you can see, there is a sustained decrease. But the figure with it almost looks like it's plateauing at that time. So individuals potentially will reach a threshold where they have a decrease in weight or potentially a decrease in hemoglobin A1C and potentially stay at that level despite continued dosing. In addition to dulaglutide, semaglutide is another GLP-1 that was studied, and a few kind of molecular modifications led to this one being tested onto the market. And in 2021, a big trial that was done for weight loss as an indication showed that compared to placebo, semaglutide led to a significant decrease in weight compared to baseline. And so in this graph here, once weekly semaglutide that was administered for obesity, as the indication in this case showed, that placebo had a modest decrease in weight loss, and this was in conjunction with lifestyle changes such as diet and exercise, and that about a 2% reduction in placebo was seen at 68 weeks versus semaglutide, as represented with the blue line here, showed a much more significant reduction of about 15 to 16% weight loss since randomization. And so these two trials really served as a basis for using these medications for weight loss as well as for diabetes. And it really led to an explosion in the different types of medication options that are out there and the continued development and marketing for these drugs because of how profound the weight loss was seen with those trials. And as a result, as you can imagine, with that profound weight loss and the degree of patients that can have these kinds of diseases and how high the rates of obesity are increasing, that there's continued momentum in the development of these types of drugs. And so semaglutide to the top left here is what we talked about with that STEP trial, and it showed that a 15 to 17% reduction was seen with weekly dosing. And so one of the hypotheses that were generated from this was that if this this therapeutic target works in that giving exogenous signals such as GLP-1 helps to decrease weight, that why not combine some of the other satiety hormones that we see or have learned about and see how that works. And that's where something like tirzepatide has come into play. And so tirzepatide is an example of a combination drug, and it's a dual receptor agonist, which composes of GLP-1 as well as GIP. And it had shown that co-administration of these in a single drug had led to a more profound weight loss reduction. A weight reduction of 21 to 25%. And there's continued development to potentially combine three of the hormones, etc., and different routes of administration. And so there is still much development and potentially more data that will be obtained in future studies for these types of drugs. One of the other developments that are underway is the development of oral administration of these drugs. That some feedback from consumers showed that some of the compliance issues with some of the earlier interventions with the satiety hormones is that people don't want to inject themselves. And so the market has moved towards potentially developing oral therapies, which might increase compliance and increase market penetration. And that's in fact some of the more recent data that we have seen. And so the Wegovy, which is one of the semaglutide medications that were a big hit, had recently the company had recently developed an oral formulation, and that was just launched late 2025. And the market penetration, at least from early on, has already seen quite a bit of popularity. And so some sources have seen that almost 20,000 prescriptions have been made for this Wegovy pill, this oral formulation of semaglutide, in the first couple of weeks of it being introduced into the market. And so there's more to come here, I think, given that this is a relatively new formulation and that it's already demonstrated quite a bit of popularity. And so, with all of this showing so far that these big landmark trials have shown effect potentially for markers of diabetes, such as reduction and significant reduction at that of hemoglobin A1C, and also significant reduction in obesity, we come back to this figure over here. As we talked about earlier in the context of this presentation, that obesity has a cascade of different effects that affect different organ systems and different body parts that lead to the overall kind of issue that we see with metabolic syndrome in general. And so, naturally, thinking about obesity being associated with higher rates of some of the diseases that you see in this figure, there has been kind of market pressure to be able to see if some of these medications, in addition to obesity, the effect of on obesity, that if it potentially has effect on other disease processes. And so this is an example by Malhorta et al., where they assessed tirzepatide, that combination GLP-1 GIP drug that we mentioned in a few slides ago, and whether or not it works for the treatment of obstructive sleep apnea and obesity. So for those of us that aren't familiar with OSA or obstructive sleep apnea, it's a disease process that is highly associated with high increased weight and obesity. And the issue with obstructive sleep apnea is that when we sleep, that the relaxation of the posterior pharynx, when we have a larger neck secondary to obesity or different anatomical variations, causes a collapse in the airway and causes a pause in breathing overnight, leading to hypoxia. And over time, if this is not corrected, can lead to cardiovascular disease and contribute to pulmonary hypertension, depression, anxiety, headaches, etc. As you can imagine, if you stop breathing for a long period of time, it's not good for you. And so, one of the ways that obstructive sleep apnea is stratified, as far as how severe it is how many times those episodes happen at night. How many times does an individual stop breathing at night? And that index is called the apnea-hypopnea index. And so, the higher the index, the more episodes you have, the worse your sleep apnea is. And so one of the trials that were looked at the change in the apnea hypopnea index in individuals that were treated were tirzepatide and placebo. And the data is summarized here in this figure one of that paper. Um, as you can see in the blue line with placebo, there was a modest reduction in both weight as well as the apnea hypopnea index. But with tirzepatide, there was a more profound decrease in the apnea-hypopnea index as well as the weight. And so this had led and contributed to the FDA approval of some of these medications for other indications in addition to diabetes and obesity, about other indications such as sleep apnea. Here we have some of the other data that has shown that there's also a decrease in further data has demonstrating a decrease in hemoglobin A1C and change in body weight. We're looking at some of the other pooled data with the ongoing studies with the different types of GLP-1s and GIPs. And the other outcomes that were measured, included some of the cardiovascular outcomes and heart failure, as well as death. And so some of this pooled data was tracked over time. And looking at some of these other endpoints, there was a reduction in cumulative incidence of cardiovascular endpoints, as well as heart failure and death. in these populations that were studied with the treatment of of obesity and diabetes with semaglutide. Other benefits that were demonstrated from this pooled data showed that there was a reduction in blood pressure, decrease in waist circumference, effects on LDL, sometimes referred to as our bad cholesterol, and also reductions in triglyceride over time. And so, in essence, the data has shown that these drugs, GLP-1s and GIP, the satiety hormones, have an effect on weight loss, significant weight loss of up to 25% with some of the combination drugs, resulting in potentially better control of diabetes with lower hemoglobin A1Cs, improved cholesterol profiles, improved blood pressure, and improved cardiovascular outcomes. And so, is that it seems like it's a magical drug, right? That this one drug could potentially have effect on all of these different comorbidities that are associated with high degree of mortality and morbidity here in the United States and worldwide. But that doesn't tell the whole picture. So in this study, that was published in 2022, the authors of the initial trial with semaglutide for obesity assessed the patients that were on this drug over time. And so the left side, this initial 68-week treatment phase was the data that you saw earlier. And what they did was for another year, track these patients in an extension phase of the trial. And the difference between the left and the right is that the drug, the semaglutide in this case, was withdrawn. And as you can see, when that drug is withdrawn, that there's a rebound effect and that there's in fact an increase again in weight and the contribution of obesity at all different levels, whether or not they lost up to 20% of their body weight initially from treatment to less than 5%, that there is a quick inflection point once the drug is withdrawn. And that this effect was not just seen with the weight, but also there was a return to baseline of systolic blood pressure before treatment, as well as diastolic blood pressure, an increase in the C-reactive protein, which is a non-specific marker for inflammation, also trended back towards baseline of after withdrawing the treatment, and also a rebound in the hemoglobin A1C. And so this suggests that potentially, if this hypothesis that we talked about of replacing these signaling hormones is an effective intervention for weight loss and different comorbidities, that potentially that these patients to have that sustained effect need to continue on these medications longer term. And I think that's part of what is going to come out in the future as far as the longitudinal studies to see what the optimal timing of treatment is and if patients need to be on this indefinitely to continue to receive some of the benefits that were published from this compelling data over the past decade or so. In addition to that, there are some side effects associated with these drugs, just like with anything else. But in general, a lot of what I see in my medical practice as an emergency physician and toxicologist is some of the side effects associated with these drugs. And so they're fairly intuitive that since this affects a lot of the GI system, that a lot of GI side effects are associated with these, nausea and vomiting being some of the more common ones. Additionally, acute gallbladder disease such as cholecystitis and cholelithiasis have been associated with this. And if the nausea and vomiting are severe enough, can lead to acute kidney injury and dehydration. Pancreatitis and some ocular things such as diabetic retinopathy and optic neuropathy have also been associated with these drugs as well. Some of the other implications associated with these drugs is the cost. And so, if you've been following some of these drugs, there's been some different legislation that the current administration has been working through with with the companies that produce these drugs to try to lower costs. But historically, these drugs, from a weekly dosing perspective, have sometimes cost from hundreds to thousands of dollars per month. And so, if patients need to be on this indefinitely, and insurance potentially might not cover it, you can see that these costs potentially add up relatively quickly. And additionally, a lot of times with the obesity population, if we stratify them by kind of socioeconomic classes as well, that a lot of times that we can see that these drugs may not be affordable to folks in poverty or in the lower middle class. And so there's potential here for improvement as far as if these drugs continue to show the effect that they show with different comorbidities and obesity, that there's a population at risk that might not be able to have access to these medications. And as a result of the cost, market kind of pressures have led to potentially making these drugs available to a wider population. And so you might have seen in the news that counterfeit Ozempic or kind of compounded drugs of GLP-1s and GIPs have been made available. If for those of us that aren't familiar with compounding, that these drugs essentially are made by different pharmacies that are independent of the larger pharmaceutical companies that have the patents on these drugs, and they combine them with potentially other things like vitamins or other kind of health molecules that are marketed as such to be able to get this drug out there, and they can charge a lot less because they're able to produce these without all the other costs associated with going through the traditional pathways. And so the FDA had published concerns about this with unapproved GLP-1 drugs used for weight loss. However, they're still out there. And one of the other topics of discussion associated with GLP-1s and these receptor agonists is if they have such a profound effect on obesity and diabetes, and we saw some of the data on cardiovascular effects and mortality, is it a drug that potentially has an effect on longevity? And age-related diseases such as diabetes, weight loss, cardiovascular diseases, and neurological conditions are some of the short list of things that these drugs are being studied for. And I think this is also one of the areas that we're going to see some more information on with future studies. We don't have the long-term longitudinal data to see if this actually has an effect on longevity, but extrapolated from the data that we have on the effects of chronic diseases such as diabetes, cardiovascular disease, and those effects on longevity, and how these drugs potentially mitigate those effects, we can extrapolate that there's potential for some of these drugs to contribute to longevity and potentially help individuals extend their healthy kind of time frame of their life and help reach their full potential that their biologic kind of clock has been predetermined for. One of the more recent studies that we were looking at in anticipation for this was the effects of these drugs on Alzheimer's disease. So, Alzheimer's disease is a very complex neurological disease that's associated with aging. And it was thought that potentially, with the effects of these GLP-1 GIP drugs and their effects on inflammation, that potentially that it could decrease neurocognitive disorders such as Alzheimer's and Parkinson's disease. And one of the trials that we were following was this EVOKE trial, which recently just came out with the data, as you can see here last month in late 2025. And what they found was that semaglutide did not significantly slow Alzheimer's disease progression as measured by some of the endpoints that the authors had described. And so, although it did not have an effect on that primary endpoint, the authors did report that there was some biomarker improvement in some of the markers that we see with some of these neurodegenerative diseases. And with that, they had mentioned that there was potentially more to investigate here, and that these medications, such as semaglutide and the family of GLP-1s and satiety hormone receptor agonists, have a potential role for the management of these neurocognitive diseases in combination with some of the other drugs. But as a monotherapy, as a end-all be-all for potentially treating Alzheimer's and preventing disease progression, so far with the publication of this EVOKE trial data, it doesn't seem like it has effect, at least from the measurement of the endpoints for Alzheimer's disease that these investigators looked at. And so, in summary, we talked about the evolution of how we think about diabetes and obesity, right? And that the pathophysiology is very complex and potentially has a large contribution with the gut-brain axis and the satiety hormones such as GLP-1 and GIP that we talked about. And that with this hypothesis that targeting those receptors with exogenous hormone that are available now, as we saw with the data, that it could potentially contribute to significant weight loss and comorbidity reduction with the exogenous administration of these medications, in addition to things like lifestyle interventions. And the data has shown that, at least from the few studies that we looked at, the GLP-1 and GIP medications have shown a 10 to 25% weight loss reduction. And we saw also the effects on some of the other comorbidities, such as cardiovascular disease, sleep apnea, as well as diabetes. The long-term effects are still to be determined, and we also talked about some of the side effects associated with some of these drugs that potentially contribute to people withdrawing themselves from the drugs or intolerance for it. And we also talked about the evolution of the cost of these drugs, as well as some of the future implications of this, such as with the oral medications that have recently penetrated the market and the initial data for neurodegenerative diseases such as Alzheimer's. And so with that, I'd like to open up the floor to any questions. We do have the Fasano conference coming up at the end of this year on November 9th, 2026, with a QR code here available for you for further information and registration. And additionally, with your CME, we have a QR code here available for you as well. So with that, I'd like to open up the floor to any questions, and I appreciate the opportunity and your attention today.
Uh,
Hey, hi,
Thanks,
Patrick.
Patrick. And I have a question, but I want to let those who may not have done it know they can type in their questions in I believe, the chat box at the bottom of the screen, and we will get to those. And if for some reason we don't answer a question you might have, feel free to email Patrick directly. That's png@fasanoassociates.com, or you can email me, mfasano@fasanoassociates.com. So the question I have before I turn on to the other ones is you talk, Patrick, about benefits for cardiovascular, sleep apnea, and so forth. At the same time, no direct benefits for, let's say, Alzheimer's or neurocognitive impairments. Is the benefit process, from what we know, a direct consequence of the drug or an indirect consequence that basically is affected through the reduction in weight? Because all the sleep apnea and cardiovascular, blood pressure and so forth, all of those conditions are impacted by obesity. So I guess the question is there any research to suggest that the benefits happen independently of the reduction in weight?
All right. No, that's a great question, Mike. And I think that that is a topic of study that is still pending some of more definitive data. With what we know so far, because there's an interplay, as you had kind of alluded to, of obesity and some of these other comorbidities, the underlying issue, I think, is that obesity is associated with different increases in inflammatory markers as well as implications in lifestyle that aren't necessarily incorporated into some of the data that we're seeing. So I don't think that there's a definitive answer for that. I do suspect that it is right now that the effect is more a secondary effect from the weight loss that we're seeing, but it does incorporate some of the things like such as the lifestyle changes that are associated with that. So when we have less weight on board and we have some of the increased exercise and better diet, that contributes to cardiovascular health in a positive way, right? And so there's this interplay of the different things that are associated with that when we can break the cycle of obesity. However, I don't think we have definitive data yet to show that these effects on the comorbidities have an independent benefit from these drugs in and of themselves. And that most recent data from the Alzheimer's study that I had shown alludes to that as well, that we don't necessarily see a direct effect on some of those endpoints that they were measuring, but that there were some biomarker differences that could also be associated with overall health benefits that we see with the weight reduction. So I think that's a very important question that needs to be answered for the future because of these things that we're seeing with the other comorbidities when folks are on this drug.
Great, thank you. We have a question from one of the uh, listeners. Weight loss appears to level out. Is that because of a limitation in the treatment or because the remaining calories taken in come into balance with calories burned?
So I think that there's several implications there. So when we see the plateau of some of the weight loss, individuals potentially might come back to their normal weight, and so they achieve a degree of homeostasis there. And so further weight loss might be actually detrimental for some of those folks. And so, with the evolution of some of the drugs that we've seen over time, where those plateaus happen at different endpoints. So some happen at 5, 10, 15%. And then with these most recent drugs, like the semaglutide and the combination drugs, we see that up to 25% reduction occurs. That I think that there are some implications on the drug and the dose that lead to this calorie balance that leads to that plateau.
Okay, thank you. Um, Got another question. Given that GLP-1 therapy often produces substantial weight reduction, yet many patients, this sounds like an underwriting question, yet many patients experience partial or full weight gain, regain after discontinuation. Uh, I'm interested in understanding how you factor this into your clinical assessment. Do you incorporate the possibility of weight rebound, particularly in cases where durable behavioral or dietary changes have not been established? So if you see a file where someone's been taking one of the GLP-1 medications and there's a weight loss, um, how do you assess the debiting, if you will, for Bill? Do you go strictly by the table, or do you discount it a little bit with the presumption that there'll be some weight regain?
Yep. So more the thank you for that question, and I think that that's also an area that we can define a little bit further. But the way I approach it is that, looking at this data over time and the other implications and health benefits that we see that are also debitable that have an implication on longevity, such as diabetes and hypertension, etc. And we see that rebound and that rebound potentially has implications on bill debits as well as the other comorbidities that we see have an effect of these drugs. That I think that it's an end all be all. And so part of what I approach here is to see if they do have a lasting effect from the initial intervention with this drug and how long that effect has been to be able to factor in how much that contributes to an adjustment in the bill debits in addition to the comorbidities that it might have been affected by. And so there's a lot of clinical judgment, I think, involved with how much that is, just getting a sense of the record and how sustained these effects are from these interventions initially. Because we see that major weight reduction, as you saw with the data, and those major changes in the comorbidities in that initial year that these patients are on, but there's that quick rebound if they come off of it, right? And so that potential sustained effect or the potential rebound if they kind of relapse and go back into those things will have those implications on the bill debits and the comorbidity debits, depending on the sense that we get from the file that we're reviewing.
Yeah, thanks, Pat. That's a good answer. And I would just add on to that the practice of um, consistency, if you will, in our underwriting evaluations and an avoidance of quick responses. So if someone loses 25 pounds in a period of 3 to 6 months, that's not really a long enough duration to justify immediately going to the debits that would be associated with the new build. If it's prolonged for 2 or 3 years, let's say, then I think it's reasonable to conclude that we've had a lasting behavioral uh, and weight change so that we would at that point uh, assess more strictly the debits that the bill chart would suggest for that weight. Um, got a couple more questions, and uh, here's one from another underwriter in the business. How many more years do you think it will be before we have enough of a sample over time to do a credible mortality study as opposed to mere clinical performance? So how much time do we need before we can, in a statistically rigorous way, associate a mortality impact from the GLP-1 medications?
Oh, that's a great question, and I think, with I'll have to kind of visit with some of the experts that are in my network to further really elucidate the answer to that question. But from what in my opinion, what I speculate is that we'll at least need another 5 to 10 years of data because some of the implications associated with that are we don't have a good characterization yet of that sustained effect and how much of the population potentially will move towards different drugs and that the type of effect on that. And what I mean by that is that, clinically, what we see sometimes is folks that are started on drug A and they either reach a plateau or they don't have, they develop some side effects and that they potentially will need to move to a different drug, to a combination drug. And then they potentially will have either a lasting effect on that one or they'll have to kind of change their strategy to something different. And then the other kind of implication that goes into this is that, as we talked about with some of the future directions and the more recent data, is that there's continued development of newer combinations of different drugs. And so that the shifting of the clinical aspect of what these patients are going to be on and what their lasting effect is on their comorbidities and obesity, and then those implications and assessing how that translates to the changes in longevity, I still think are a few years out because of those different changes as well as the observational data that still needs to be collected. Um, so I would say, in my opinion, at least 5 to 10 years out, but that's just kind of my opinion based off what we've seen so far and my pulse of kind of the market with the developments and what we see clinically with all the variables that go into changing their management from a side effect profile and an efficacy profile.
Great. Um, we've got a terrific question. Sounds like an actuarial uh, a question to me, but it's uh, the impact on health benefits or health mortality, morbidity for someone who is obese and then loses the weight by virtue of a GLP-1 family of drugs versus someone who never was obese at all. So we, for example, when we look at mortality associated with smokers, there's a continuum from heavy smokers who've always smoked and are still smoking versus never smokers versus all the gradients in between of prior smokers who quit, let's say, at a young age versus those who quit more recently. And we try to adjust for that in our underwriting. What would you say of that same dynamic as applied to weight loss and the improved prospect for cardiovascular health and so forth? Is it black and white, or is there a similar continuum in terms of health impact, depending on whether or not you started at as obese, severely obese, and so forth,
Right.
versus never having been obese?
Yeah, no, that's a great question as well. And Mike, I think the analogy with smoking applies here in a similar kind of thought process as well. If we think about all of the different disease processes and things that have a lasting effect, potentially, even if they're corrected, that those effects are still there, and that there's a difference between folks that have gotten the disease process compared to folks that did not get affected by the disease process or the exposure initially. And so, with your analogy of smoking, I think it applies here as well, and that there's a continuum for somebody that was potentially overweight or obese, and they had the comorbidities associated potentially with that. How long, they were associated with that, and how uncontrolled they were and so that implies a severity of kind of the disease process that they lived with, and then when they're corrected, how long they sustained the correction for. And so I think there's a continuum there. And that there's a difference in that individual that had obesity and had it corrected versus someone who was not obese at all versus someone that continues to have obesity. What those numbers are. I don't think we have objective kind of robust data like we do with smoking to be able to say, X translates to Y at this point, just because the data is not as mature as the smoking data. But I do think that same kind of logical reasoning applies. That once the insult is there, that there are lasting implications, and that there are other factors such as severity and duration of exposure that contribute to that as well.
Yeah, great. Um, One question, and I think we have time probably just for one more. Are you aware of any newer trials that would have better racial balance? So the trials that are out there, at least the initial ones, appear to be heavily biased towards Caucasian and perhaps Asian individuals. Are there studies underway? And this, may reflect the demographics of our country that disproportionately white and Asians uh, are higher income than non-whites, and therefore uh, typically don't, typically will get the newer medications and better medical health. But setting that aside, do you see any studies in the works that would apply and look at the benefits or the changes applied to a non-white population?
No, that's a great implication, and I suspect that as you had mentioned, Mike, the potential access to the medications and the demographics that we see regionally are contributing to some of that. But the short answer is no. I don't know of any specific kind of trials underway that are looking at answering some of these questions from a specific demographic standpoint. And to I don't. Most of the time when we make some of the conclusions scientifically for some of these things, they're done in retrospect with subgroup analyses. But I don't know of any specific trials that are looking at things from a demographic specific perspective at this point in time.
Okay, well, we will keep our eyes out for that, and of course, share information through our newsletter and other venues as we get it. Um, Including the Fasano Longevity Conference, which will be on Monday, November 9th this year. And so I would ask everybody to mark that in their calendar. We'll be having more research, medical research presentations as we always do. So we hope to see some of you there. Patrick, I'd like to just thank you again for an absolutely great and thoughtful presentation. Somebody really insightful must have recruited you to Fasano Underwriting because you've been a great addition. Um, so with that, again, if you have further questions, feel free to email me or Patrick, and we will get back to you. And for now, we'll see you next time. And thanks again, Patrick. Have a great day.
Great, thank you.